Okay, thank you very much. I think we'll make a start. It's 4 o'clock, and welcome to this session. This is RC301, refresher course in the GI course, looking at the cross-sectional imaging of colitis. My name is Stuart Taylor from London. I'll be sort of chairing this, but the main work will be done by our three excellent speakers who will be guiding us through the role of imaging in disease of the colon. And as I'll go through, we'll have a session at the end for all your question and answers. So please do save them up. I'll just remind you to fill in your CME forms to get your points for staying this long on a Thursday. Okay, so I'm going to set just a few slides, not very many, just to set the scene for our speakers, because I say they're going to cover all the sort of work for us. When I think of the sort of topic that we're going to talk about, these sort of three questions come into my mind. So we were either, as radiologists, we're given a patient with suspected colitis, and the gastroenterological surgeon asks us what imaging test we would do, and then we would decide what test we would do, and then how would actually do that test. That's one sort of clinical scenario. It's quite common. Another common scenario is we're doing our cross-sectional imaging reporting, be it CT, MR, and we find an abnormality of the colon, which we think is probably colitis. So again, how do we deal with that? What further tests do we recommend? Can we characterize the colitis ourselves on the imaging and give at least a valid differential diagnosis based on what we can see? And then I think probably the third most common scenario is we know the patient's got a known diagnosis, so Crohn's disease or ulcerative colitis, and we're asked to look at the large bowel and decide how active the disease is, how extensive the disease is, whether the therapeutic options the gastroenterologist is using is actually working. So I think we can probably categorize how we think about colitis in those three main clinical questions. And of course, in the back of this, and we have to remember that the colon is very easily accessible to the endoscopist, so we've got a very good test that's probably not in our hands as radiologists, and that's the endoscope. And these are just typical pictures. They can see the mucosal lining, they can see very subtle things. And I'll show you an example of probably how we can't see things as subtle as an aphthous ulcer. They can also see advanced things, and again, perhaps that's where we can compete with them, because our technologies can get very good images of these more advanced stages. As with radiologists, we've got a whole host of modalities available to us: ultrasound, CT, and MR are the main three, and we're going to hear about those in the first talk. We're going to decide which tests should we be using and when between those three, and how do we actually do it. We're looking at the large bowel. Do we put fluid in the large bowel before we do the test? What are the nuances of the individual protocols for that? And Dr. Smith will talk about that. Then moving on, if we find a patient with colitis, can we work out what the colitis is? How do we integrate what we do with the endoscopists? We see things beyond the bowel wall which the endoscopists don't see, so perhaps we can give further information which they can't. And again, I go back to the question, can we give a differential diagnosis or even characterize the colitis with our cross-sectional techniques? And Dr. Gallet will talk about that. And I mentioned before the endoscopy. These are two cases with Crohn's disease, with proven colitic disease. The first one, I think we'd all agree, we'd all be happy with that. There's an abnormal thickened colon, and we can diagnose that pretty well with MR. This patient's also got colitis with aphthous ulcers on their colonoscopy. Most of us would call the colon normal there, so we're not going to see the small aphthous ulcers. So how does that tie into how we use our cross-sectional imaging? And the final scenario is whether we know the patient's got inflammatory bowel disease. We know the endoscopies are pretty good at doing that, but what can we offer to them? We can look beyond the bowel walls, as I mentioned. There's a lot of work now looking at scoring the activity in Crohn's disease, particularly using MR, and it's less invasive techniques compared to the colonoscopy. So I think we've got a lot to add in the patient with known inflammatory bowel disease, and Dr. Rimler will talk about that. He'll talk about some of these, the validated scores that us as radiologists are now coming up with, and sort of adding these to the tools the gastroenterologists can use. As I mentioned, please do ask questions, but we have a panel discussion at the end, so it's probably best if we hear the three speakers one after each other, and if you can save your questions to the 15 minutes at the end, we'd be very welcome to hear them.